All right. Hello, everybody, and welcome to this session. I'm very excited to be on this wonderful panel, moderating it with Dr. Eugene, Miss Laure, and Chaste. All of them have such wonderful insights into the cultural and language of Rwanda. I want to introduce us to a video that we're going to be playing next, which will help us introduce this topic in a better way. It's a video that was asked to women and men of Rwanda. They were asked several questions in regards to the topic that we've been discussing for the past few days. It is based on mental health and how it can be approached in therapy and what it means to Rwandese people in this country.
Mbyumva kugira ubuzima bwiza bwo mu mutwe, nyumva ari ukugira ibitekerezo bizima, nta n'uburwayi ufite bwo mu mutwe no gukora ibintu bizima abantu babona uko mbyumva ngewe. Kugira ubuzima bwo mu mutwe nyumva ari ikintu cy'ingenzi, kuko nta kintu wakora udafite ubuzima bwiza bwo mu mutwe. Ubuzima buzima nyine buzira umuze nyumva ari ikintu cy'ingenzi, yaba mu mikoreshereze tugira muri iki gihugu, yaba guhinga ntiwahinga udafite ubuzima, yaba gucuruza ntiwacuruza udafite ubuzima, yaba se kuba uri umuyobozi ntiwayobora udafite ubuzima. Noneho by'umwihariko bwo mu mutwe ni ingingo ikomeye cyane. Nari ngiye kuvuga ngo umuntu ntawe yaba atandukanye n'irobo, ariko irobo nsigaye mbona nayo ikora ibintu byinshi muri iki gihe by'ikoranabuhanga. Ubwo rero umuntu udafite ubuzima bwo mu mutwe ntacyo aba ari cyo.
Bisobanuye kuba umuntu yumva ari muzima, nta kibazo afite mu mutwe, afite amarangamutima mazima, afite ibyumviro bizima, ndetse ashobora no gusabana n'abandi neza.
Njye numva ni igihe wumva muri wowe mu mutwe wawe nta kibazo wumva ufite, mu gihe wumva utekereza neza, ibyo ukora ukabikora ku murongo, wumva na stress ufite.
Kugira ubuzima bwo mu mutwe buzira umuze kuri jyewe icyo bisobanuye ni ukuba uri umuntu udafite ikibazo, ni ukuba ushobora kubana n'abandi neza muri sosiyete, ni ukuba wumva uri tayari mu mutwe niko njye mbyumva.
Ukuntu mbyumva kugira ubuzima bwiza bwo mu mutwe, ukuntu mbyumva nka kwa kundi umuntu ushobora kuba nta kibazo ufite, utekereza neza, nyine wumva nyine umeze neza, nuko nyine mbitekereza nuko mbyumva.
Ntakigeze tubona ngewe. Bibaye ngombwa numva nta kibazo cyantera twabonana. Ntabwo twigeze tubonana umuganga w'inzobere ubuzima bwo mu mutwe, keretse umujyanama usanzwe. Ndibuka yanganiriza ku by'igituntu, nari mfite inkorora, njya kwisuzumisha ku mujyanama w'ubuzima, ambaza niba iyo nkorora nyuma y'ibyumweru 2, tubiganira ndangira inzira nacamo kugira ngo basuzumire ko ari igituntu. Ni urwo rwego.
Kugeza ubu ngubu ngewe ntabwo ndabonana n'umujyanama wo mu mutwe, kuko ntabwo ntabwo ndagira ikibazo cyatuma njya kumureba, ariko bibaye ngombwa mu gihe numva meze neza aba ari itegeko ko njya kumureba.
Ntawe ndagira amahirwe yo kubonana nawe, ariko ku bwanjye numva ese nabonana nawe nta kibazo.
Ntabwo turabonana, ariko biramutse bibaye ngombwa nabonana nawe.
twigeze kubonana, yego. Inshuti yanjye yari ifite ibibazo, arabyigumanamo akabinganiriza, mwumvisha ko akwiye kujya kureba inzobere y'ubuzima bwo mu mutwe kugira ngo abimuganirize amufashe, ariko nkabona arabitinya. Byansabye ko nsanga umujyanama hari ku bitaro, nsanga inzobere mu buzima bwo mu mutwe, ndamuganirira, mubwira ikibazo inshuti yanjye ifite, bityo ngira inama bituma njya kumufasha.
njyewe mbona ku giti cyanjye mbona nta mpungenge zijyanye n'umuco zanduza kuba twavugana nawe, numva ntacyo bibaye ngombwa. Numva nta mbogamizi yaboneka kuri njye yatuma ntagana umujyanama w'ubuzima, ntayo rwose. Numva ahubwo ibihe byose namugana kugira ngo ndusheho kumenya ubuzima bwanjye uko buteye.
Umuco nyarwanda akenshi abantu ntabwo bakunda kwifungura, ntibakunda kuvuga ibibazo byabo, buri gihe yumva yakwibikamo kubera gutinya ko ibyo bibazo bye byajya hanze, kubera kuburira icyizere uwabibwiye akumva ashobora kuzabisohora, bityo bigakwira hose. Ibyo rero bigatera ingaruka y'uko abyigumishamo, bigatuma nawe umujyanama w'ubuzima atamusanga amwirekureho, mbese amufashe icyo kibazo.
Imbogamizi zishingiye ku muco, twebwe nk'abanyarwanda akenshi ntabwo dufitemo culture yo kumva ko twakora ikintu mbere y'uko kiba. Urabona mu muco w'abanyarwanda nk'uko namaze kubivuga, ntabwo bumva ko nyine kugira ngo ukore ikintu ari uko kiba kimaze kuba, warangiza ubundi ukajya gukora ukabona kujya kugikemura. So ni kumva yaba imbogamizi nyine.
Urabona nko mu muco nyarwanda, sinzi ko navuga, hari ukuntu navuga nko kutisanzura, ukumva uratinye, bigize nk'ikintu ukavuga ndakigumanye, sinshaka kugira ngo bacyumve, sinshaka kugira ngo umuntu amenye iki kibazo runaka, kuko igihe bashobora kugufata ko wenda uri umusazi, kandi mu by'ukuri atari ubusazi, ari ikibazo wagize runaka kindi.
Nko mu muco nyarwanda kera habayeho kujya umuntu yitinya, ninjya kwa muganga wenda baravuga ko mfite ikibazo cyo mu mutwe, ariko aka kanya ntabwo ariko mbyumva. Aka kanya numva yuko kubonana n'inzobere mu bijyanye n'ubuzima bwo mu mutwe byamfasha cyane, kuko biramfasha kumenya niba mfite ikibazo hakiri kare bakagikurikirana. Ikindi bikamfasha kwimenya uko ndi kano kanya.
I hope everyone could understand and see the video well. I would like to introduce my panelists so that everyone gets to know them. On my right, we have Dr. Eugene, and he is the Associate Professor of Clinical Psychology and Psychotherapies. And right next to him, we have Laure. who is the founder and global coordinator of Sana Initiative. And on my last panelist is Chaste, who is the national coordinator for Rwandan-based NGO named Uyisenga ni Imanzi. On this panel, we're going to be having questions, and these are for the different backgrounds, and we're going to explore ways in which we can improve and approach the different people in Rwanda. My first question is going to go to Laure. And it is, as the founder of Sana Initiative, could you speak to us about the challenges you faced creating this organization? Which challenges were due to cultural factors and which ones were caused by other factors?
Thank you, Jade. I would say that Sana is an organization that has a mission to break a stigma and raise awareness around mental health issues, but also reframe how therapy is perceived in our culture and hopefully on the continent at large. Now, when you talk about the cultural challenges that we faced, it's important to first understand that Rwandans have gone through a lot. We are a population and a country that has gone through a lot. Now, when you are asking someone who has been wounded so much to look back and observe intently their wound in order to heal from it, it takes a lot of courage. It takes a lot of, it's not everyone who's going to be willing to do that, because after everything that has been happening, that has happened, with the resilience of Rwandans, the focus is more and was more on let's rebuild, let's focus on other things. Now, looking back to the wound can be very, very challenging. On top of that, you have to also understand that in our culture, we have, even in the proverbs that we use, right? We have this belief that we deal with our own things on our own, right? Rwandans are the kind of people who, we're the kind of people who will talk about issues in the community in terms of, in order to solve them. But when it comes on talking about our own pain, we usually don't go there. And we even have proverbs and sayings in our language, in Rwanda, where we use things like amarira y'umugabo atemba ajya mu nda, right? Agahinda k'inkoko kamenywa n'inkike yatoyemo. So we're the kind of people that, and even the lady in the video mentioned it, we don't necessarily go out there and talk about our pain, right? And speaking of talking about the pain, there's also another factor. We are a population, a people whose social fabric has lost the sense of trust. Now, even if I wanted to talk about my own pain, sometimes I wonder, who am I going to tell, right? Who can I trust enough to be able to tell them what's going on in my own life, right? So the challenge culturally was in terms of like those three combined things, but also the generational gap. As a young person who started this organization, looking back and thinking, the things that I observe, the things that I see as a young person, the way I perceive mental health today is not the same way a 50 years old is going to perceive it, right? I'm glad we're talking about language and culture. The generational gap also was palpable, is still palpable. However, the good thing is now the world has become like a village, you know. I don't have to travel to the US or to Australia to get to know how they're evolving and developing in terms of understanding mental health and breaking the stigmas and raising the awareness around that topic, right? So however much it's been challenging, there's also been a lot of good things that have happened in terms of starting these conversations and making sure that slowly but surely, the same way we've been developing the country economically and in other areas slowly, surely, and steadily. We're also working on the mental health part of things, and I'm sure we're gonna get there.
Thank you so much for that. I'd like to go to Dr. Eugene. Given Rwanda's recent traumatic history, I mean, as Laure talked about previously, do you think there's a greater inbuilt understanding for mental health issues within our culture? And have you seen a shift in how people perceive mental health issues and in associated language after the 1994 genocide against the Tutsis?
Well, it's a really a good question, and we need to, to try to understand from the beginning. When we look at and when we talk about mental health, that time, we really made a long, long way. We are used to refer to two times. One is before 1994 genocide and after 1994 genocide. Because, with the genocide, it's like after genocide, everything was destroyed, mistrust. Culturally, we are the people who are not really trust each other. Sometimes I'm not sure that's what testimony, what I'm going to talk to you, it's gonna stay between you and me. And when genocide came, that was horrible to see how people, the cohesion of the whole society was destroyed. And before 1994, when we talk about mental health, it's like they were nothing. They were nothing. Only Ndera Psychiatric Hospital, you are getting crazy, you go to Ndera. And people really, you do understand how people were really stigmatized. If you are there, if you are going to Ndera Hospital, it's finished for you. Even you recover and you come back to the society. That was all the time they are seeing you, someone who gets psychological disorder. So in terms of resources, in terms of professionals and mental health, in terms of concepts to really talk about mental health, we didn't have. So straight after genocide 1994, we were like, that was like anesthesia of everyone. We were in kind of darkness for everyone, and we didn't know what to do, how to do it, how to face it. And it's usual. I do remember the first time I came from Burundi, that was in 1997, and WHO sent a kind of manual to say, you are going to get different psychological disorders. So go there, expert from WHO, and then you are going to meet people, some people starting in mental health. You keep in touch with them. You try to see how to do with this manual. We were around 10 people. And we start to think about mental health through this kind of manual made in Europe, taking different concepts from Europe, Western countries, and then to start to think how to teach people and how to get people and to talk about mental health. That's what the beginning, and we start by translating the manual. We start by meeting in the whole country, teachers, to say, if we need people understand this kind of problems, we have to pass through those opinion readers like teachers, religious, etc., etc. That's what the first time we start to say. That was around 1997, 8. And then the problem was to say, when we talk about symptoms, what we really talk about. And the question was to say, if you are talking about PTSD, what does it mean to me, to you? Trauma, what does it mean? And then we start to looking for some concept in Kinyarwanda, like ihungabana. That was the first time we used the concept to talk about trauma. Ihungabana and ihahamuka. We tried to get some concept, but that was not really, people were not really, that was a kind of contradiction from different associations. That's, but now we can really define trauma in Kinyarwanda and try to come back to the specific symptoms related to the trauma. That's what the way we made. And other challenge was like, in time of trainings and in time of resources, we didn't get anyone. And they said, they sent 2 people, Rwandans. We come back to, to the culture. They said, if we need Rwandans get about mental disorder, let's send some Rwandans living in Europe. That was 2 psychotherapists from Belgium to start by teaching people, to start by reviewing manual, to start by, to show the first aid for those people. And, the government tried to, the first time they knew it's a kind of challenge, they create a center that's called Trauma Recovery Center. That was financed by UNICEF in collaboration with Ministry of Rehabilitation. But the mission was clear to say, you help children, only children because of UNICEF. And we found everything. If not, that was a crash because everyone was coming. Children, adults, everyone. And UNICEF said, no, we could not continue with you. That was the second challenge. And Ministry of Health start to, to take the leadership and to say, we take now, we have a division of mental health. Through ministry, we have the policy of mental health. We have, really different structures from the ministry level up to the community. That was really the improvement. And then in time of teaching and trainings, we create, the Department of Clinical Psychologists. Chaste is one to get a master's in clinical psychology and therapeutics, inspired from the culture. So they are getting different theories, but we try to involve something like ethnopsychiatry, how to understand mental illnesses in Rwandan context. So this is really a big improvement. In time of researchers and research, the first time I remember Harvard came, other Western universities came, 1995, no Rwandans. That was one, he was in Harvard, of course. And then they start to, to conduct different studies with vulnerable groups like Vega, like, orphans, etc., etc. And today we can say we are so proud to see different Rwandan researchers doing the same work trying to understand different questionnaires to diagnosis and the treatment and to adapt those questionnaires. So we really improved, and I'm so proud to be part of.
No, thank you so much. To be honest, listening to everything that you've said and how far the country has come in terms of addressing mental health, even with all of the challenges, it seems that we always seem to pick ourselves back up and address the issues that always affect our people. So thank you very much for that. That was very insightful. I'd now like to go to Chaste. And you've completed various research projects on the topic of mental health, rehabilitation, and healing. This was mentioned by Dr. Eugene, who is very happy to be working with you on so many things. And can you elaborate on what the research indicates is the role of the culture and language in tackling mental health issues?
Thank you very much. I will start with the quote from Alfred Adler. Alfred Adler is one of the famous psychology Fred time. He said, "We are expert of psychology and psychotherapy, but people are expert of their lives." That's how culture is very important. And I will say that culture itself is identity, and you can never tackle mental health issue without going back to personal identity. One of the issue in my work, in my researches, I found is that people are expert. They know their problems, and even sometimes they know how to name them. They know they are the only ones who see their pain, their suffering, because most of the time the emotional, the feeling pains, there is no laboratory which can really see those kind of pains. So the only person is the one who is seeing. So culture is very important, and those pain are named culturally. Sometimes we say we do not have languages, and we do not have words, we do not have names. But me, I say, absolutely we have. But the biggest thing you want, which we cannot be possible, is trying to translate feeling names from a culture to another culture. We want to translate what Western feeling pains, Western emotional behavioral pains have already named in their languages, and we want to translate in Rwanda and in our context. That's most, sometimes I say, the impossibility we have to name in our culture. So diagnostic itself, it has to be based on a culture. Because when you are hearing even a patient themselves and the names, the recent research I'm conducting, I found around 80 experiences of people where among them they say it's a kind of darkness. While it may be an Occidental person would say it's a depression. He would say it's a confusion. While he would say it's anxiety. He would say it's like emptiness. Another would say like that. So culture is very important to understand a person and to make a pain understandable by both a therapist and a person, because the meaning, even from psychoanalytic perspective, one of the objectives of psychotherapeutic orientation is finding this emotional insight, this emotional meaning, and the emotional meaning can never be found if you cannot consider a culture. The other thing very important I found is that most of the time we like, as I say, we want to import names, but sometimes also we want to import tools. But we have also tools. That is what I realized, that culture, in every culture, they have tools and practices. And those practices we were discussing outside when we were discussing about rituals and the other tools and practices, which are very important in either even in the diagnostic process and even in the treatment process. And I find that when you focus on those Occidental culture, you are stuck just in the diagnostic. You just use those different checklists which have been standardized, and when you find depression and so what, and what next? But if you go to culture, you will find really good tools, and I like to say psychological language and psychopathological language. When you see culturally, Laure was mentioning a very good proverbs. It's a metaphorical language, and you will never understand a metaphorical language when you are not in that culture. That's how culture is very, very important. And when you are going even to treat, sometimes you use metaphorical tools, and those metaphorical tools can only be found in culture. That's a little bit how I found that how culture is rich, and even when we were just following the film, I'm initiating another project called the MAP, Mobile Arts for Peace, where even when we are defining mental health, sometimes we just go to those Occidental definition, but people, they can even define. And those definitions are more important that maybe the definition we are getting from DSM or from any psychopathological language, but a definition from local for a culture, for a mental health problem, or a mental health disorder, of a psychotherapy, of a tools, that is more helpful in the healing process. That is how, in summary, I can say how culture is very, very important. And finally, just to finish, I will say that in the therapeutic process, I was following the previous session where they end up saying that therapy is at the same time arts, creation, and science. Me, I will say that therapeutic, every culture, every country should have its own psychotherapeutic style, of course, basing on one or many psychotherapeutic theoretical perspectives. Thank you.
Thank you so much for that. I think I'd like to go back to what you said in the beginning of answering your question, and that is to know who you are, you need to go back to who you've been. And in your answering, it opens it up to say that culture affects you in ways that you will not know. We all grow up in very many different metaphorical things that we're given for solutions. And if you have a problem, you come to someone close to you, and the culture is the backbone for a lot of who you are, how you're raised, how you're going to go into the world, the culture of your place, your people, your home. So to know that language plays so much into that, I just wanted to reiterate that. Thank you so much for that. Let's go back to Laure, and the second question I have for you is, your work is highly focused on challenging the traditional perspectives on mental health. What have you found to be the most effective way to do this without alienating individuals that are more conservative, but while ensuring that this important message is delivered?
Yeah, thank you, Jade. I'd like to begin by saying that human beings, the one thing that, among other things, the one thing that we share is we are conversational people. And the other thing, like Chaste mentioned it around identity, is that every single one of us is at the quest of belonging. And we belong to an identity, we belong to a culture, we belong to a country, we belong to the world, right? And sometimes, even more important, we belong to each other. And when you talk about when we talk about the generational gap, or the bridge between the generations, it's good to understand that we even have a saying in our proverbs. Again, I'll go back to the proverbs that we use in our language. Utaganiriye na se ntamenye icyo sekuru yasize avuze, which somehow translates to, if you don't talk to your father, you will not know what your grandfather said before he passed, or something around those lines. Now, heritage, thank you. Now, what we figured was the right way to approach such a topic that is surrounded by a lot of stigma, again, understanding that people stigmatize things they don't understand, or people stigmatize things they're afraid of, or people stigmatize things they're not entirely familiar with. So we realized the best way was not to tell people, hey, it's better that you go seek help, but rather start with a conversation, right? We made sure that this topic is out there in the public. Let's talk about this. Let's make sure, with the help of different practitioners, with the help of different, again, generations, let's sit across the table. Let's have public talks. Let's have conversations in schools. Let's go to the workplace and see, if you have a workplace that has people of different ages, how do they cope together? How do they belong to each other? What kind of language do they use in terms of understanding what mental health is? So the most effective way for us to approach this topic, we figured, was going to be conversation. And then we started with that. We created platforms with the help of different practitioners. We held different public talks, free of charge for everyone to come and actually discuss this topic. We also have to understand that, like Chaste was mentioning, our language has a lot of nuance, right? For example, when we're talking in English, for example, and I ask you how you're doing, your answer is going to be, I'm okay, or not so good, right? Or I'm not fine, right? When we talk about, if I ask you the same question in our mother tongue, in Rwanda, there's some people you're going to ask, Muraho, for example, and then they respond to you, they tell you, yewe, ndabona bucya bukira. They haven't told you if they are okay or if they're not okay, but from what you're observing, for example, you'll be able to tell, oh, this is what they mean, right? So education, psychoeducation, again, back to what we did, creating conversations, focusing a lot on psychoeducation without necessarily being prescriptive and saying this is what you have to do. This is according to all the researches that were done or that have been done on other continents, we figured, let's talk about this even in our own language. Yeah, let's figure out, when I say A, what do I really mean? What is the nuances in our culture? And even for the people who are treating, the practitioners, I'm sure if practitioners were to just follow the checklist, the anoxis checklist, they will be facing a lot of more challenges. But it's the nuance in the language, it's the focus on educating each other because we belong to each other. Yeah.
Thank you so much for that addition. It really blends well with what Chaste had to say about countries should have their own systems of diagnosing mental health issues because of the language and the contexts in which we even use our body language that people don't put into perspective about the communication styles that we're putting out there. It's the way we talk, the way we lean towards a word we're saying, and this can be picked up if it's studied particularly in your culture and your country.
And by different people in different generations. You know, if they sit together across the table, it's easy to now say, hey, back in the days, this is how we perceived this topic. Now, for you who are young today, this is how you perceive it, but it's not entirely different. We were just facing different kind of issues and different kind of struggles and in a different kind of understanding.
I think this is to go back to the conversation we were all having before about the different concepts and ways people lived before us, even before all of us on this panel, and why they lived the way they lived. There were the reasons behind it, but there was also a lot of support in regards to the way people did live. I think I'd like to move on to Dr. Eugene. And my question for you is, you've worked with various local and international NGOs in Rwanda. What is the role of NGOs in challenging negative cultural perceptions of mental health? And how can they work cooperatively with the government and community leaders to make this a reality?
Well, I would like to, you allow me to start by a bit to talk about the language. The language, when, as you said, when we're talking about the language, it's not really the language like tongue. You know, it's a kind of, you are going to express your emotions. You are going to, you know, to express your feelings. The kind of, you are breathing, I know the state you are, you know, the mood you are living up today or to present. So if, you know, the kind of attitudes, the kind of non-verbal way is a kind of language. And in Rwandan context, it's a rich country, rich people in kind of expression. Even if you go in, you know, some good events like, you know, you are going to get in marriage with the kind of to say yes or no, you are going to take your knee and then you say yes. This is from Western countries, but you are going to accept, but I need to capture, you know, to know how Rwandan girls are saying yes, even in disorders, it's the same. So the language is not really to say, I'm speaking to you. Just I need to get everything from you, from the way you are seeing me, the way you are reacting, the way you are. So in Rwandan context, in psychotherapy, we need to understand that if you are coming from, you know, Western countries, that's gonna be hard to you to get everything. So, okay, let me come back to your question. The question, you know, when I look at those NGOs, local and international, they really did a great job. You know, civil society helped a lot the government of Rwanda. they have taken the leadership. And let me give you some examples. Let's say, you know, when we talk about trauma, trauma is issue of disconnection. You are disconnected I'm disconnected to you and to the community as well. The way we are going to do and to help you is to, you know, to reconnect the patient. And I guess those associations, let's say, for example, Avega, ARG, Ibuka, they realized that they are going to die. They were isolated after 1994. You are in your side, but it's like you are dying, you are disconnected. They said, we have to get together. That was the first important decision they have taken, to get in association and then looking people to help them. We stay together, we fight together. That was the logic behind. And if we take, for example, how those young people at university, ARG, they were supporting each other, for example. That was very interesting. So, in spite from the culture, all the time, if we are facing an issue, we're facing together. We get together and we deal with these kind of problems. So that was very interesting. And then they get together and, you know, outside people, good people, they came to help them, but together. So that's what the first time we start to, you know, with some expert like I'm going to, you know, to support them, to supervise the team, but we're going to elaborate together. So one of the best setting was to create what we call therapeutic groups with specific rules, how we are going to interact in small groups, and then to try, you know, it's like we are helping each other. You help me, I help you. It's not, they said we could not get more professionals, and then we are going to use the same community. We are going to use those associations. That was a good idea to say, let's empower them, and then when they are getting strong, they are going to help each other. That was the therapeutic groups. Now, up to date, to present, we are in the whole country using this approach to make people together, homogeneous groups, to talk, to interact. You said about, you know, I'm getting connection when I'm starting to come to you. And this kind of interaction is really useful when you are using it in the groups. So let's say, for example, if I take an example for international NGO like Handicap International, they have developed what we called community approach to make the society a healing society. I'm not going to, you know, looking more expert in psychology, in psychotherapy, but I need all people within the community to know and to fight about what you said. If you are responsible in the community, I'm taking you as one who is going to help other people with, you know, different problems. So that was very important to fight the stigmatization. The stigmatization, because when you are getting trauma, when you are getting mental disorders, you were stigmatized in the community. So we start to use the community once again, to use those associations within the community, to use opinion leaders within the community, to use local authorities within the community. So each citizen is responsible to one another. This is a good approach, and I realize that we need, to increase those people through psychoeducation to take, the leadership within the community. Now we have, for example, different association, like, let's say, like Never Gain with youth. They are going to the community and make together different, young people with different identities. I'm survivors, but you are children from genocide perpetrator, for example. We need to meet and to talk. What happened? Maybe I'm suffering in my side, you are suffering in your side. So the kind of organization go to the community, help the people to strengthen the community by talking and by to sit and talking. Another NGO like Prison Fellowship, for example, they are developing with other people what we call sociotherapy. Sociotherapy is just the same philosophy to go in the community, take the people, the same, this community, and to handle those kind of problems. So, and then the collaboration with, the government and division of mental health is very interesting, because at level of the district hospitals, we can get those professionals, and there is different meetings, and they meet to discuss to everything, and then to say, if you are going to, for example, if you are in Rubona area, the second NGOs which is coming, I send it, let's say, in Kibungo to share and to allow those people to get more, helps. And I found that this is very important. The civil society is doing well, is doing good job. And I hope, and the collaboration is good, because the policy of mental health is good to say it's coming from the high level up to the community. So I hope, I'm not pessimist, I hope we really, we are doing a good job within the community, and we have to go far and to stay improving.
Thank you so much for that. I would like to add that to what Laure said and what Chaste said, it seems that for even it to work at a level of NGOs internationally, nationally, it seems that we all have to break down a level of shame within the conversations that we're having, and to show that you're not alone in the things that you're going through, that there are people before you, people who were before them, and people who are with you that are now going through still the same kind of things. So everything you've said is just, it keeps on adding to the conversation we had earlier, that when you have a problem, it becomes a problem of the family that you're in. That means your community comes to you and says, it's not all those Yubibazo, no, it is, how do we help you? How can we put a hand here? Please do not feel like it's just you that's going through it, because if you are hurting, then the community hurts as a whole, to know that you think you're alone. Thank you so much for that. I have one more question for Chaste, and then we're going to continue to the audience's questions, of which thank you, audience, for watching. As a therapist who has led rehabilitation and trauma recovery programs, how detrimental is a negative perception of mental health illnesses for the health outcomes of the patients? How can we make this negative impact common knowledge in order to start tackling this problem?
Thank you very much. Yes, you are right. People with mental health problem are somehow marginalized. I like to say they're somehow named with what I can call ridiculous or demeaning names, which push them to feel a little bit lost. I will propose just 5 points, just to tackle and to handle that issue. The first point is, first of all, dignifying people with mental health problem. How to dignify them? It's just finding those dignified names, local names, contextualized names, Rwandan names, which are dignified. The second point is just demystifying mental health therapy and mental health support. How to demystify it? It's just to make it simple. Psychotherapy is simple. It's not just something, how can I call it? But just we have to demystify it, and so that we can let people to come to see us. It's a normal thing. The third point, I want to, it's just to separate a person from a problem. How separating a person from a problem? Even traditionally, a mental health disorder was something which was coming from outside of a person. It's 2 different identities. There is a problem identity and there is a person. If you say this is a depressed person, what do you want? There is a depression and a person. That's so separating a person from a problem. That goes to the next point, which is 4th, creating the new story. The new story, which is a story of capability and a story of skills, and coming from a story of vulnerability, the story of incapability of those people who have a mental health problem. And the last point, we have to learn. We professionals, we practitioners, we psychologists, we have to go back to our community and to learn from even patient and from even community. And this learning will help us to create a new knowledge. And this adapted knowledge, this adapt practice, the practice which is coming from culture, from context, that is the 5 point I want to propose, which may help us maybe to dignify maybe one time people with mental problem. Thank you.
Thank you so much for that point. Well, now we're going to move on to one more question from the audience, which is for all of you. And the question is, do you see problematic patterns of mental health by gender? In general, do males demonstrate pathological disorders differently than females? And are there also patterns that distinguish younger people from seniors, generation 1 and 2 post-genocide? Any of you can go first.
Let me start. They had the question, but you will start. Let me start with the last question. The generation and generation and generation. I like to categorize mental health problem after genocide in 3-4 categories. Just in 94, 95, people were in a situation where they were still in confusion, in denial. They were asking themselves, is it really the genocide really happened? Is it really happened? My family members really died. And when you continue 98, 2000, even up to 2005, it's where now it was really a deep, if I can see, a deep destabilization. Those who are living here in Rwanda, you remember when we're having trauma crisis, and you could see like all hospitals full of people, the whole school system of more than 1,500 students are in emotional crisis. They were really deeply, if I can say, destabilized. And nowadays, we are starting to ask ourselves, what is happening in us? There is now the problem is starting to be really mental problems, and there is something now which is coming to us. You cannot sleep, you have a headache, you have those mental health symptoms, but you don't know what is happening. That is a generation which is coming from genocide and even before. And then the second generation, the younger people who are born after genocide, they are starting having what we call intergenerational trauma or intergenerational problems, while they are asking themselves, what really happened? What is happening? And they are also developing a kind of a phantasm of genocide. And they are phantasming, is it English? I don't know. But they have those phantasm of genocide, and then they are creating those problem. That is a little bit how I can talk on the last question. I cannot remember the two first question is.
The question was, do you see problematic patterns of mental health by gender? For example, in general, do males demonstrate pathological disorders differently than females, or the other way around?
I will come back a little bit on the culture. Female are females, male are males. They are different. They are different, and even in Kinyarwanda, you will see there are proverbs saying that amarira y'umugabo atemba ajya mu nda. Culturally, men in the Rwandan context, we are not allowed to cry outside. That's a little bit, but ladies, women, girls, they are allowed. But also, you will see in men developing other, if I can say, coping strategies. You will see so many young people, young men, men now who are using drugs. They take another orientation of getting alcohol and drug just as a protection mechanism. Even when those who we are intervening in the commemoration, since I have been a part of the team, national team who are intervening in the commemoration, when you see the people who are having problems, you will see, because it's most of the time we receive those emotional crisis, you will see more ladies, like more than even 60% of people we receive are ladies, are girls, and women. So there is some difference in manifestation, in the coping strategy, but I will say we are all human beings and we can all feel pain.
Thank you so much for that. I would just like to, before we wrap everything up, do you have any comments that you'd like to make before the session is over? Anything that you'd like to add on that you feel that you did not touch on? Just a thought, an afterthought, something that a piece of advice on culture and language within the Rwandan context.
All right, this is me. Well, I would say, I don't like to come back to what said my friend Chaste, that is true. Statistics are showing that during different commemoration period, we are more observing that girls, the number is consequence. If you go from girls to the male, female, male, that's it's understandable because we know men in the Rwandan context, we have to stay strong. And I'm not sure, but they were saying that if you go to the Ndera Psychiatric Hospital, you are going to get more males. Maybe you stay, you are not showing this at that moment. You know, the kind of crying, it's a kind of expression. It's good for you. You are crying, it's a kind of, you know, expressing your emotions. Yeah, maybe if I stay, like people are used to say, we hide in the stomach. If you don't want the dog cheat what you are getting, just hide it in your stomach. And it's like a secret as well. The secret, or you are just hiding it in your stomach, and then you are getting trouble. You are going to show other symptoms showing that you are not, you know, you are in trouble. Yeah, this is one. The second comment is related to, you know, transgenerational trauma. The first generation, the second one. You know, there is a kind of ways, I will mention three. One is, you know, the kind of, I'm going to build my relationship with you. I'm parents, survivors, and you just came, you were very young, or my mother was pregnant that time, you didn't see. But, you know, theories are showing if you are in, in your, sorry? Yeah, if you are not, you know, you are stay before you birth, you are getting those feelings your mother is experiencing. So one of explanation was to say the kind of, I'm going to, you know, to educate my child. It's like sometimes you prefer to protect your children by not saying anything. You keep silence. When you keep silence, it means your child is going to, you know, to elaborate different scenarios you have experienced during the genocide. You are not saying it, but I'm living it. And you are living your side, this kind of, you know, silence. And in silence, I'm living the same experience. So this is a kind of transmission. Even you didn't speak, you are, you know, you are, it's like you are transmitting these kind of worries, you're kind of, during the commemoration, you are going to in your room and you close the door, you stay. Maybe, I don't know if you are crying or not, and in dining room, for example, but I'm saying, what is she doing? So this is one way. The second way, that's gonna be how you are going to, you will be maybe more aggressive because of, you know, you are getting trauma. You are aggressive when your child is asking the question, you are not responding, but you aggress the child. This is kind of transmission as well. And the third one is more scientists related to epigenetics transmission. Now we are sure, and we have conducted the kind of research to see how genetically you can transmit some genes to your child, and that time we are sure we can identify the type of gene, and it's not like genetic. Epigenetic is the environment which is going to change you. If you are in bad environment, you are going to change somehow some mutation in your body. This is 3 ways to, even you are the first generation and the second one, this is kind of transmission. Now we are conducting the study for the second generation. We will get more results very soon.
Thank you very much.
Mine is more of an encouragement. It's true that we live in a world where everything that we go through and everything that we do, the world is just full of a checklist. And to go back to what you were saying earlier, the checklist that boys growing up have to go through and the checklist that girls have to have can be different, especially now in our culture, different. However, I just want to encourage people and tell them to be intentional. Remember that life is in itself is a journey. Be intentional about your own mental health and respect someone else's journey. You know, be intentional about your own journey and respect someone else's journey. And it's important for people to remember to take care of themselves, remain brave, and always kind, because even though mental health, culture, language can be, we can find obstacles, but there's also hope that we can prevail and be better.
All right, I just want to thank each of my panelists for such a wonderful, wonderful conversation. Coming into this, I already knew it was going to be extremely insightful and important, just as this whole event has been. Thank you, Dr. Eugene. Thank you, Laure. Thank you, Chaste. I think the message that's being passed on here in terms of culture and language is take the time to understand the culture that you come from. Take the time to understand the language emotionally, body language, and verbally. And it affects you more than you think you know, but all in all, it plays such a large part in your life and who you are. So do that research, get to know yourself, and thank you for being part of this.